Thank you, Beth, for that wonderful introduction. I just want to say thank you to the committee, Dr. Sharma and Dr. Kinney, for inviting me to speak with you all today. It's really been a privilege. It's going to be a privilege. And I want to thank all of you here today, whether in person or virtually, for joining us today. Thank you for coming. Good morning. Again, my name is Henley Wu. I'm one of the cardiovascular specialists here at Mount Sinai. And today, again, my topic of discussion would be mechanical circulatory support devices, mainly in the context of our Cath lab. So I have no relevant financial relationships to report. And a little bit of an agenda, kind of what to expect in the next few minutes. The key points I want to talk about today are: one, what exactly is mechanical circulatory support? Number two, give an overview of some of the common mechanical circulatory support devices we have here in our Cath lab. And number three, go over the future of mechanical circulatory support. So what exactly is mechanical circulatory support? Well, the goal of mechanical support is to restore cardiac output and to preserve end organ function. Basically take over the function of the heart. So most every device that we go over today, we're going to be talking about how they can augment our cardiac output and hemodynamics. Now, in addition to cardiac output, we also have to talk about offloading the LV. Often, STEMI patients, even after revascularization, can still exhibit symptoms of shock, even post-PCI. And what's happening here is, in this case, the LV myocardium is experiencing myocardial injury. Often there's also volume overload, so the ventricle is stretched, increasing your oxygen demand. So if you can actually offload the LV, you could decrease and shrink down the LV EDP. You're going to promote healing because you're also going to be lowering your oxygen demand. So basically, in mechanical support, you're trying to optimize the balance between myocardial oxygen supply and demand, which gives you time to allow the myocardium to recover. And we have a couple of choices in the Cath lab devices to do that. And the ones I'll be going over today are the intra-aortic balloon pump, or IABP, your Impella devices, and ECMO, or extracorporeal membrane oxygenation. So I kind of broke down these devices kind of into two big groups, mainly your continuous and non-continuous flow, and also your intracorporeal and extracorporeal devices. Again, this is by no means an exhaustive list, but I rather hope I can give you a brief overview of what it is that we commonly use here in the Cath lab. Now, depending on where you are, what the expertise is, and depending on who your attending is, really that's going to be the factor in choosing what you're going to be using. So what do these devices look like, and what are the pluses and minuses of each? And the first device we're going to look like is the intra-aortic balloon pump, or the IABP. Now, the idea of a balloon pump is rather simple, relatively speaking. It uses a helium-filled balloon, so this is going to be your pulsatile or pneumatic device. This is also going to be inserted retrograde through the femoral artery into your aorta by a 7.5 French arterial access. And basically, the catheter is just a catheter with a balloon wrapped around it. And during diastole, it's going to inflate, and during systole, it's going to deflate. So how does this help us? Well, as you all know, in diastole is when we're going to be perfusing our coronary arteries. So when your balloon inflates, it's actually going to not only stop the blood flow forward, it's going to push some blood flow backwards, perfusing your arteries. And this is a good choice in the Cath lab. Let's say you have a patient coming in with an end STEMI, and you find the patient has really severe 3-vessel disease, or the patient needs to wait to go into complex PCI or CABG, you can elect to put in a balloon pump in this patient because it's going to, again, augment our coronary blood flow. Now, our balloon's going to now deflate during systole, and not only that, it's going to actually also create a vacuum effect. So you're going to pull blood out of the ventricles as well, and that's going to be your afterflow reduction. So again, the main points for your balloon pump: number one, augmentation of your coronary blood flow, and number two, your afterflow reduction. Right? So what are the contraindications for something like this, a balloon pump? Well, aortic valve insufficiency, or AI, is going to be a relative contraindication. Remember, in diastole, if our balloon is inflating, instead of perfusing the coronary arteries, the blood is now going to get pushed backwards into our ventricles as well. Right? Another contraindication here would be aortic dissection. If you imagine you put a balloon pump in a patient with aortic dissection, you're going to be causing propagation of that dissection all the way down, and cause all sorts of troubles for the patient down the line. And that's what some of you definitely want to avoid. The next device we're going to talk about a little bit today, this is going to be your Impella devices. This is specifically the left-sided Impella. And we have a couple of choices for that, your Impella 2.5, Impella CP, Impella 5.0. All slightly different, but the principle is kind of the same. This is going to be a microaxial flow pump, also known as kind of like a suction device. This is now a little bit bigger than your balloon pump. This is a 14 French access for your Impella CP, 13 French for your 2.5, or surgical access or surgical implantation for Impella 5.0, so quite a bit bigger. But the principle is the same. Like I said, this is going to be a pigtail catheter that sits in your LV across the aortic valve. There's going to be two ports here, your proximal and distal port. Distal port is going to sit in the LV. It's going to take blood out of the ventricle and put it in the aorta, mimicking the normal blood flow of the heart, right? So because now the Impella fully unloads the left ventricle, it's going to offload or lower your LV EDP, right? And it's going to overall reduce your end diastolic pressure and also lower the mechanical work of the heart. So Impella is a very good choice if, let's say, your patient is primarily low cardiac output or low EF, but everything else like the lungs and the right heart is okay. And in the cardiac cath lab, we can elect to put an Impella in a patient besides cardiogenic shock for high-risk PCI, because we're able to not only provide myocardial protection, but also provide hemodynamic support. Another note about Impella, this device is rather positional. Remember, we talked about these two ports, your distal intake and your proximal output port. If you imagine this Impella going a little bit too deeply, where both of your ports are in the ventricle, you're now just taking blood out and putting it in the same chamber, which is not really doing anything. The same idea is if you go a little too much in the other direction, your blood is now being only taken out of the aorta and putting it back into the aorta, which is something you don't want as well. Contraindications for a device like this, remember this is a 14 French sheath or bigger, so not quite as big as your ECMO, but almost 2 times larger than your balloon pump. So peripheral vascular disease or severe PAD is kind of a relative contraindication. You really don't want to put Impella through somebody like this. Next, this device has to sit in your left ventricle, so it has to go across the aortic valve. So anything with your aortic valve will be making it very difficult to use your Impella. In this case, would be something like aortic stenosis. And also an absolute contraindication here would be LV thrombus. So remember, this is a suction catheter. If you have LV thrombus and you use a suction catheter, there is a chance that you can take that thrombus and you send it all over the body. And again, that's something you really don't want to do, right? A little bit note about the Impella RP as well. When we spoke about the Impella, we said that the left side Impella is a really good choice if your primary problem is low cardiac output, low EF, and everything else is okay, but that's never really the case. What if you had a problem, or had a patient with a problem of not only a down LV, but a down RV, right? You could put a left side Impella in this patient, but the left side Impella is not really going to help the right side of the heart, right? Your primary problem is your blood's not getting into a pulmonary circuit, into your left heart and rest of the system, but that's where the Impella RP comes in. Impella RP, very analogous to your Impella CP or the left side Impella. It's also microaxial pump with a suction catheter. Notice that this is now a venous access, 23 French, quite a lot bigger. But the way this sits, this catheter now is going to be sucking blood from the vena cava into your pulmonary artery. So again, takeaway points here are patients with RV infarct versus the left side Impella, Impella RP, much better choice. Contraindications, I went through forward, but contraindication for the Impella RP, again, analogous to your left side, you wanted to avoid LV thrombus. In this case, for the Impella RP, you wanted to avoid pulmonary embolism. You don't want to stick any catheters through PE. And also, again, I mentioned the 23 French. Anybody with peripheral vascular diseases, you want to try to avoid doing a really big bore access like that. Now, next, we're going to finally talk about ECMO, extracorporeal membrane oxygenation, especially pictured here. This is VA ECMO. VA ECMO is a very, very large bore access, 2 cannulas that goes into your femoral artery and femoral vein. This is upwards of 23 French sheath. This is, again, a continuous flow centrifugal device. It's going to take blood from the venous side close to the right atrium. It's going to take it through your pump into your oxygenator, back into your femoral artery, into left side axis. And this provides full cardiac support. So what does that mean? So this is doing both the job of the heart and the lungs. And this is the way I like to think about it. It's kind of like almost bedside bypass. Not exactly the same as when you go to the OR with the big machine, but very, very analogous because you're bypassing both the heart and the lungs. So you can imagine the patient population that is going to be needing or being considered for ECMO or VA ECMO are usually very, very sick. Now, you can't talk about VA ECMO without talking about VV ECMO. Now, granted, in the Cath lab, we don't do VV ECMO a lot because it's essentially kind of like a lung bypass. But like the name implies, this is venous to venous ECMO. You're taking blood from the venous circulation back into the venous circulation after it goes through the oxygenator. And we saw this a lot during COVID. A lot of patients with severe ARDS where their lungs were pretty terrible, but their heart was relatively okay. You could potentially use this device, take blood from the right side of the heart, put it back into a pulmonary circuit without worrying about needing to be oxygenated. So this was very useful during COVID. And finally, my last point I'm going to touch upon is going to be a little bit about the future of mechanical circulatory support. Prior to me going to the Cath lab, a little bit about myself. I was a paramedic for about 10 years in the New York City 911 system. I worked my fair share of cardiac arrest, MIs, et cetera, but I can only recount on one hand the amount of patients that I can remember that walked out of the hospital neurologically intact. But that's not surprising, right? We all know that after about 20 minutes of resuscitation, that a patient's chance for a good outcome is essentially zero. So a lot of hospitals have recognized this, and they have developed and start using ECMO into their cardiac arrest resuscitation protocols in something known as ECMO, CPR, or ECPR. And the goal of ECPR is just like what we're talking about here in mechanical support, which is to maintain end organ perfusion, but in this case, so a reversible cause of cardiac arrest could be corrected. Usually this is like a major vessel blockage. Now, a lot of pilot programs in the US have already, in the US and Europe have already begun with a lot of promise. This is going to be pictures from Paris. I believe this is in Paris Metro in the Louvre Museum. This is started in 2011. And more recently here at home, this is 2019 in Albuquerque, New Mexico. So if you can imagine, something like this requires a lot of coordination between pre-hospital and hospital services. Everything is still very, very fluid. Current ECPR protocols require that ECMO be initiated 20 minutes after resuscitation, but studies have shown varying degrees of success from 8% up to 29%. However, what I think is very clear is that frontline ECMO or pre-hospital ECMO is a very viable option to treat patients that need it. And so in conclusion, I know we went through a lot and rather quickly, but I hope that I had given you a nice overview into the different devices that we have in our Cath lab. And more importantly, I do hope that I kind of tickled your imagination as well into what is possible and what is going on currently now in the field of circulatory support. Thank you very much. If you guys have any questions or comments, please reach out to me and I'll be glad to get in touch with you. Thank you.